Warm evening to everyone. Myself Ruchita from FDC. Welcome all the doctors, our panelists, and the moderator for very important talk and the discussion on topical antifungals. The scope of topical preparations are increasing day by day, and we take this opportunity to bring the panel of best dermatologists of India. Today we are going to discuss about the scope of topicals, various topical agents, their role, right topical formulation and how to select the right vehicle. To have elaborate discussion, we have eminent team of dermatologists. To carry forward the session further, we have renowned dermatologist and the moderator, Professor Dr. D.G. Saple sir. Sir is Honorable Professor and Head Dermatology, Venerology and Laparology at Grand Medical College and Sir J.J. Group of Hospital, Mumbai. He is pioneer researcher and clinician in HIV/AIDS in India. First dermatologist in India to use fluconazole 150 mg daily dosing. Also consultant in dermatovenerology, laparology and HIV/AIDS at Breach Candy Hospital and SL Raheja Hospital and Fortis Associate at Mumbai. He was ex-president IIDVL Maharashtra branch and ex-president College of Physicians and Surgeons at Mumbai. He had delivered 1001 lectures across the country, represented the country at over 108 international forums. Also, he has achieved more lifetime achievement awards. Also, Best Practitioner Award at Dermacon International Congress 2019. He had honored as a mentor for IDVL Fellowship Derma 2020, and his current research project is dermatophytosis. So, welcome, Professor Dr. D.G. Saple, sir, and all session is yours, sir.
Okay, thank you, Ruchita. I think, yeah. Can you project it? Good evening to everybody, all panelists, audience. That today flow of our webinar. First, we'll have a talk from Dr. Manjunath Shenoy. After his talk, we'll have panel discussion, and then we'll open for the questions from the audience. And lastly, a vote of thanks from Ruchita. So Ruchita can have this biodata of our panelists. Yeah, our speaker is Dr. Manjunath Shenoy, which is very well known across the country. But when you're talking about his introduction, he is from Mangalore. He is a past convener of IDVL Task Force against recalcitremia, SIG recalcitrant dermatophytosis. He was IDVL National Vice President 2020, President of Karnataka 2015. And he has got publications, 73 publication, presentation more than 100. So Dr. Manjunath Shenoy will, I think, will go ahead for the introductions of panelists also. Yeah, Dr. Jha has not joined, but I think Ruchita is likely to join. No, you must have. Ruchita?
Yes, sir. Yes, sir. I talked in the morning. He will join.
Okay, again, please remind
One
him.
more. Yes, sir.
Yeah, so
Sure.
Dr. Aman Kanja is from Patna, is ex-principal of Patna Medical College, ex-National General Secretary of IIDVL. He has got oration, Glaxo oration, and recently he got Lifetime Achievement Award from IIDVL National. Next panelist. Our next panelist is Dr. Satyadarshi Patnaik. He is a professor and the HOD in the department at DVL, MCS, Bahrampur, Odisha. He has got teaching experience last 22 years. He has got academic honors and is known for organizing QTCon 2008 and 2017, ASTICON 2017, and is convener for awardee committee IDEAL 2020. We'll have now next panelist. Yeah. Next panel is Dr. Dhananjan Damble. He is practicing Pune, but he has finished his MD from Grand Medical College, where I was a teacher. He has got 7 publications, more than 15 presentation, and he was a secretary of Pune branch. Then he secretary, joint secretary, sorry, secretary A, and immediate past president, and he became then joint secretary of Maharashtra. He has got a best published work in mycology at the National Ayurvedic Conference. So that's about Dr. Dhananjan Damle. And now our last panelist is, sorry, not last, second last, Dr. Santosh Rathod, Santosh Dev Rathod. He is from Ahmedabad. I know him because he has done his fellowship for HIV under me in Mumbai. He is more known for his leprosy work. He is a conversor for SIJ leprosy in 17, 18, 19, and 20. And if you see, he is known for his book, One Rounds in Dermatology. So he's the editor of One Rounds in Dermatology, and his special interest is leprosy. Now we'll go for the next panelist. Yeah, Dr. Rajat Kandari from Delhi. So he has got special degree that more than MD dermatology is MSc non-surgical facial aesthetics and consultant dermatology in New Delhi. About his publication are there in national and international. He was president IIDWL DSB in 16 and 17, and he was honorary secretary in 15 and 16. He has got a scholarship from WCD and Professor Patrick Echudin scholarship. He's, he is a part of SIG laser aesthetic and psoriasis, both. His special interest is special aesthetic, melasma, sunscreen, and laser for scar reduction. So I think now we'll hand over mic to Dr. Manjunath Shanoy for his talk.
Thank you, Supply sir, for your kind invite to be a part of this webinar. Yet another opportunity for me to learn and interact with the best of the faculties across India and also with the learned audience. Thank you, FDC, for your invite and making me part of this webinar on dermatophytosis, the burning issue across India. We often interact, Dr. Saple sir and others, something which we don't understand what is happening with dermatophytosis in India. We are still confused, although we are having this onslaught for the last over 5 years, maybe 6 to 7 years, but still we are a little bit confused about what's happening. And although quite a few things are known, and by and large, there are more questions to be answered than what we know. Today's topic is on topical therapy. Now, topical therapy is so integral in the management of dermatophytosis, is that we basically want to hit the fungus by all directions. Current trend of treating dermatophytosis is all about hitting it from all directions. It could be topical therapy, it could be systemic therapy, how best you can tackle, and with good strong evidences. There needs to be evidences whenever we use something, and that has to be very important. Now, as was just mentioned in the beginning, that recalcitrant dermatophytosis is not just in India. We are facing that all across South Asia. There are reports of difficult to treat tinea elsewhere too, and by and large, it's in the South Asia. I believe this is going to be a global issue sooner or later if we really don't find a solution to this. And most important thing, what probably could have contributed is the indiscriminate use of steroid containing creams, which is easily available in India. This is the biggest issue which needs to be very carefully issued. It has to be handled, and right decision will have to be taken. There is a availability of potent topical corticosteroid and antifungal along with antibacterial combinations which are OTC in India, and they are misused, abused by the dermatophytosis patients, often prescribed by people who do not have sufficient knowledge about the topical therapy or overall management of dermatophytosis, or which are dispensed by the pharmacist without any prescription. So this is a very important issue, and with this webinar, and I'm sure Saplis also will agree that this is the most important message we would like to give in addition to having some knowledge on topical antifungal therapy. So as I mentioned, one thing which we know is there is a dramatic shift of isolates that we see, the fungal isolates in dermatophytosis, that is Taenia corporis cruris, especially the glabrostemia, is that shift from Trichophyton rubrum to mentagrophyte. And we believe mentagrophyte, there are some evidence to say that this is much more, the pathogenicity of the Trichophyton mentagrophyte is much higher compared to rubrum, because mentagrophyte is more inflammatory, yet it can spread to larger part of the body, which is very difficult to understand. And what mentagrophyte we have is a different mutated strains, which is currently prevailed in India, is a mutated strain which has got which probably has happened due to this potent topical corticosteroid abuse, which is the over-the-counter medicine still in India. And we have been facing this problem with longer duration of treatment and possible drug resistance too. We have familial aggregation of cases with ping pong effect. That means when one is treated, the other person gets the infection, by which it doesn't leave the family. A lot of economic burden also is faced by the family which have been going through this dermatophytosis. Now, how important is topical antifungal? We need to use topical antifungal in every patient with dermatophytosis. That's the bottom line, whether he receives systemic antifungal or not. But the problem is feasibility. Sometimes we do get a patient with a highly, very extensive disease. It becomes very, very expensive for the patients to use topical antifungal to such a large area. But other than, if not for that, the topical antifungal is must. And such topical antifungal is a first line in all cases, as I mentioned. But in addition, we have situations where systemic cannot be used. For example, a patient who is pregnant, where we prefer to avoid systemic antifungal in lactating women, in infants, and also in patients with serious organ system diseases, say for example, a liver disease patient, a renal patient, where we have limited option of systemic antifungal. And these are the situations where topical antifungal will have to be used, and often they are used alone. But otherwise, in the current scenario, we have to use systemic antifungal in every case. And best thing about topical antifungal is there is no drug-drug interaction since it's given topically. And what's an ideal topical antifungal? We are yet to find, I believe. It should be highly effective against all strains of dermatophytosis, should have anti-inflammatory action, should have rapidity in its response, good penetration, good reservoir effect, viscosity which is ideal and ensures a higher release through the vehicle, minimum systemic absorption, potent enough for a shorter duration of therapy. Once a day convenience should be there, and low risk to develop resistance. And finally, the cost effective. If we have all these features, you can't expect it to be cost effective, that's for sure. But still, we are looking for such an ideal topical antifungal. Now, how do we classify antifungals? We should have some idea about how these antifungals are classified. This is topical antifungal classification. The most commonly available topical antifungals belong to the azole category of antifungals. Ketoconazole is an imidazole, and others also like iconazole, bifenazole. And we have recently the better version of azole, that is triazoles like fluconazole, itraconazole, and efinaconazole. Most of these are available in India except which is systemic, which is not available in India, but it's supposed to be a very novel molecule, and it's available across the world for the onychomycosis therapy. But in India, efinaconazole is not there. And then we have allylamine, which acts through.
Manjunath, sir?
Yeah.
Yeah, your screen is not moving, sir. Sorry to interrupt.
Is it?
Yeah.
Is it moving now?
Sir, I think it's best if you can
reshare. Yeah, I'm doing it.
Just share again.
Is it visible now?
Yes, now it is.
It's moving as well, right?
Yes, now it is.
Okay, yeah. So azole antifungals, and the novel molecule is efinaconazole. And then when it comes to other topical antifungal, we have allylamines, benzylamines, then cycloperox, which belongs to the hydroxypyridone category. Morpholines like amorolfin, tolnaftate, which was once available, now currently it's not available, thiocarbamates. Echinocandins are not available topical to the best of my knowledge, it's only systemic. Polyenes are available like nystatin is available, amphotericin is available in topical formulation. These are all available in India. Oxaborole, which is tauberole, is not available in India. It's also available abroad across the country. It's approved for onychomycosis. There is a newer investigational drug of interest, that is ME quadruple 1, which is a different molecule which acts by succinate dehydrogenase enzyme inhibition, a critical enzyme in the mitochondrial respiratory electron transfer, which is different than the action on cell membrane or the cell wall. So it's a novel molecule which we look forward to. Probably it could be a paradigm shift in the topical therapy if it is available. Most of the antifungals, as I told, they act by inhibiting the cell wall or the cell membrane. So this is the primary problem with us, because except for few like morpholines and cyclopirox, which work by a slightly different mechanism, but by and large they all act through by inhibiting the cell wall or cell membrane, especially cell membrane. Most of them, azole, salylamine, they all, except echinocandins, which are the thing, but echinocandin is a systemic drug. Now coming to the topic of the day, that is liliconazole. What is liliconazole? Liliconazole is a novel topical imidazole antifungal. It's a relatively new antifungal. We all know this. It's available in India for the last probably about 7 to 8 years. It's basically an optically related compound to the lanoconazole, which is also a very novel molecule. It inhibits almost all fungal agents, including the dermatophytes, Candida melasthesia, which are of importance to dermatology. It has a very high fungicidal activity against. It has a fungicidal, although it's an azole. Normally, you expect it to be fungistatic, but because of certain good properties it has, it can be considered even as a fungicidal, especially against trichophyton species. The advantage is it has a reservoir effect, because of which one can use it, apply it once a day. And if you see the foreign literature, you see for Tinea pedis it is just 2 weeks. For Tinea corporis and cruris it is 1 week. But in India, if you say 1 week therapy, we all would laugh at it. It's a joke. However, it's a good molecule. We may have to use it for longer duration, but they are decent. And if you see over here, some of the best of the top antifungals are compared here for their minimum inhibitory concentrations. You see here, liliconazole has got as low as 0.00012 for trichophyton rubrum, and probably not more than 0.004, which says such a small amount of drug is sufficient to inhibit the fungus. That means it has got a low MIC, which means high potency. So how you have to interpret this? It has lower the MIC, the potency of the molecule is higher. It's higher compared to, it's got a higher potency compared to all other commonly used antifungals. That is something to be understood. Liliconazole, that's why liliconazole stands out as compared to any other molecules, because of its low MIC. So that's something to be understood. And then it has got a broad spectrum activity against all dermatophytes. As I mentioned, the MIC range for epidermophyton flocosum is as low as 0.016 microgram, and for Microsporum canis is also 0.016 microgram per ml. And liliconazole is highly active against Candida as well, at a very low MIC, whereas terbinafine does not have an effect against the Candida especially when it's used in topically as well as systemic. We don't use it in Candida except when you use a combination antifungal therapy. Otherwise, terbinafine is not used in the management of Candida. It has got a good efficacy against the yeast melasthesia as well. So that is why it has got a broader spectrum and low MIC. So broader spectrum, low MIC, and the reservoir effect. So these are some of the novel activity of liliconazole, which one can easily understand. It can have very important clinical implications. Since it has got a reservoir effect once a day application, as I see here, it's recommended in this particular study, wherein the PK analysis in 12 subjects, all subjects received liliconazole cream once per 1 person for 15 days in intradigital thing. Low and minimal systemic absorption was also detected and indicating it as a safety as well. So it has got a good safety features as well. Now, clotrimazole is a drug which has been used for decades, and let's not rubbish this molecule because we have a newer molecule. Because although we do have some studies, it's not concrete enough to say that one molecule is superior than other topically, especially in topical therapy. Because in vitro studies like MIC studies may not exactly tell whether you can extrapolate those information into clinical medicine. It's very difficult to tell, especially when it comes to molds, when we are dealing with the molds like dermatophytosis. So it's an imidazole molecule, and it has been a therapy for masses. We have used it for probably trillions of patients so far, and has been very good drug. But now it is the time for a newer molecule, because we know once any molecule used for many years, and probably it might lose its efficacy, and certain advantages too we may get with the newer molecules like liliconazole. So here there is a comparison between clotrimazole and liliconazole, and surely you can see this arrow indicating that a much higher comparison of mean reduction scores from the baseline to the end baseline is much better for liliconazole as compared to clotrimazole. So relapses are also much higher with clotrimazole as compared to liliconazole. It's only 4%. And when it was compared with the topical terbinafine, and it was found that terbinafine is definitely lesser efficacious as compared to liliconazole, or at least liliconazole is as effective as terbinafine in this particular trial. For patients with terbinafine mild contact dermatitis as well, so which is not seen with the liliconazole. So these are some of the pictures with liliconazole as well as terbinafine. You see good clearance with the liliconazole therapy. To conclude, 2 weeks once daily application of terbinafine and liliconazole are equally effective, at least. This is a British Journal of Pharmaceutical Research paper. Miconazole is yet another drug which is used in the masses, and it was compared with liliconazole. And once daily application of liliconazole improves the patient compliance as compared to the miconazole, which requires 3 to 4 times a day. That's something which is an important point to be noted again. So once daily application is a definite advantage, and it was also compared with another important molecule, topical molecule, that is bifonazole. 73% patients in liliconazole showed negative fungal culture test as compared to bifonazole, which is only 50%. So indicating mycological cure was better with the liliconazole. This is a mycosis publication, which is one of the top journals across the world when it comes to fungal infection. So, and then other antifungals like eberconazole, ambrolfin, and cetoconazole. These are relatively newer molecules. All these, in fact, ambrolfin is the newest. It's a much different molecule also. It's not a azole or triazole. It is a morpholine derivative. It acts by inhibiting 2 different enzymes, the reductase and isomerase. So it's a much different molecule, which means you expect it to be a novel molecule. Generally will have different mechanisms. You expect it to have a higher efficacy, but when compared with liliconazole, this is one of the study. You can see that liliconazole and eberconazole, ambrolfin, and terbinafine were compared with each other, and endpoint efficacy was shown to be much higher for liliconazole as compared to terbinafine also. And when it comes to ambrolfin as well as eberconazole also, the efficacy of liliconazole, one week once a day application of liliconazole was more effective. And yet another study wherein terbinafine, cetoconazole versus liliconazole was compared. And in this study, liliconazole and cetoconazole was able to achieve the inflammatory symptoms like pruritus and erythema much better as compared to terbinafine. But although I don't see there could be some statistical difference between 96 and 100, but one thing for sure, it is at least as good as the other molecules like cetoconazole and terbinafine. So yet another study wherein this is an in vitro study wherein you see this again. The MIC values are much lower as compared to all other topically and even systemic antifungals. When it comes to systemic antifungals, you can see the itraconazole has got the lowest MIC values against species like common species like Trichophyton interdigital, rubrum, tonsurans, and Flacousin epidermosphyton. So MIC and 50 and 90 values for luliconazole had excellent activities than terbinafine, itraconazole, glycophyllin, indicating luliconazole is more efficacious compared to, more potent compared to other drugs. Another study on the sensitivity pattern, you see here luliconazole seem to be having definite advantage as compared to other molecules for all these three species, the verrucosum, rubrum, and metacophyte. And yet another study where there was a head-to-head comparison between some of the more recent molecules along with terbinafine, which is an allyl molecule. This is our own study. So I was involved in this study, so I know about this. It's very difficult to get a patient suitable for topical therapy alone because you need to have a very limited lesions, which is not easy. So we had only 20 patients each in this group, and that's why we didn't get a high impact publication. But we could see that in our study, luliconazole definitely had a better symptom control as well as the efficacy. So overall, the statistically significant improvement in the inflammatory parameters overall was also statistically significant as compared to other molecules with luliconazole. Luliconazole had a much better improvement in the symptoms, and that's how we could, to at least to some extent, we could say that luliconazole is a better molecule as compared to others, at least in this, as far as this study is concerned. This is some of the pictures wherein you see that a good amount of reduction with all molecules for that matter, but terbinafine, we were not happy with the terbinafine. Percentage reduction was much lower. So again, luliconazole showed much better. You can see it is only topical therapy used in this patient and several other patients too. There's only post-inflammatory hyperpigmentation which is remaining in this patient, indicating luliconazole definitely has got a better symptom control as well as the clinical cure rates. Cycloperoxy is a novel molecule because it also works by a different mechanism. It inhibits the trivalent cations, thus interfering in the activity of certain enzymes like trivalent cation dependent enzymes like catalase and cytochrome enzymes, some of the cytochrome enzymes, which is one of the old molecules, one of the older molecules. Even that seemed to be no comparison to luliconazole when it comes to in vitro studies. The MIC values are much better for luliconazole. So I think we have done a good amount of the discussion on the various studies. These are some of the other drugs, other molecules we use: gentian violet, psyllium sulfide. Tramoxine is not an antifungal; it's an antipruritic. Even that seemed to be handy in the current scenario. Antipruritic effect could be of advantage, especially when it is used in the therapy. So now coming to an other important aspect of topical antifungal, the vehicle. Now, most of these topical antifungals is a combination of the active compound and the vehicle. Vehicle is as important as the molecule because if we use a suitable vehicle, and then the absorption of the topical antifungal across the stratum corneum is much better. Viscosity is also very important. The efficacy of topical antifungals in superficial mycosis depends not only on the type of the lesion, the mechanism involved, but also on the viscosity of the molecule that we use, vehicle that we use. Here we have, one important vehicle which is called capric triglyceride, which are medium chain triglycerides. This is one of the important advent in the topical therapy, and having such vehicle can have higher release of luliconazole, that is the active ingredient at the stratum corneal. Hence, there is a better absorption. Now, this medium chain triglyceride itself can have antibacterial, antifungal activity. It has something like an emollient-like effect, so skin softening, and also maintains the pH, which is an important issue because I was discussing about the topical steroid abuse, which can also impair the cutaneous functions. Skin functions can be disturbed by the usage of topical antifungals. So hence this becomes an important molecule, important vehicle. The MCT, that is medium chain triglyceride vehicles, are very important. If any product which has this could have an advantage over the others. So this is also an important message. Apart from the therapy per se, the antifungal therapy, one should also focus on some of the general aspects like hygiene, treating the family members. One should also be aware of the importance of COVID-19 impact. A lot of people have lost jobs, and or they may not be getting the salary to their fullest. So there is an impact of COVID on the socio-economic status of the country. The high treatment cost could be a real problem in such category of people. So liliconazole can be cost effective because it can be used once daily and shorter duration of therapy. So you may probably require lesser number of tubes as compared to other molecules which have to be used at least twice a day. So that is one of the important aspects. Although liliconazole may appear slightly expensive than other molecules, but this particular aspect makes it fairly cost effective. And the takeaway points with liliconazole, to summarize, is it's a potent broad spectrum activity antifungal. But what bothers us is a trichophyton species where it has got a lowest MIC compared to any other antifungals. It has a shorter duration of therapy and once daily advantage, because of which patient can become more compliant. Higher clinical as well as mycological cure rate. The disease recurrence chances are lesser, reduces the fungal resistance because the low MIC is nothing but the lesser chances of fungal resistance. Reservoir effect as well as favorable safety profile. Because of all these properties, one should consider liliconazole should be considered as probably top priority topical antifungal. It's a little expensive molecule, we all know that, but it has these advantages. It's a relatively newer molecules are all generally more expensive molecules, and that's why one should understand that this could be the reason why it's expensive. And finally, what is more important about topical therapy is that currently we have to use anything that is systemic as well as topical with a lot of caution. We have to justify our usage, and when it's needed, we have to use it properly. Of course, we have to use them. Aggressive therapy is very important when we deal with the fungal infections of late. And finally, one important point, once again, I reiterate the importance of not to use the steroid-based combinations, because that is one of the reason why we are facing. We all believe in that. So thank you for your kind listening. I had to rush through because there were a lot of slides, and we are going to have a good discussion moderated by none other than Saple sir. So Saple sir, kindly take over.
Okay.
Thank you.
Thank you, Dr. Shanoy. It was really wonderful presentation. You have covered most of the point, but I think all of us, we are waiting for the inputs from the panelists. So we'll open for the panelists. So Ruchita, can you share my slides? Can you allow me to share? Yeah.
Meanwhile, others can also switch on the videos as well as audio, sir.
Yeah. I think when you're gone from the, you're off sharing, eh?
Yeah. Stop sharing, sir.
Yeah, okay. So.
Yes, sir. It's visible now. Slow, not yet, sir. Yes, sir. You can open that.
Yeah, now it is open, eh?
Yes,
yeah.
Yes, sir.
Yes, okay.
Make it full screen, sir.
Yeah. One second. Yeah.
Yes, sir.
Yes. Yeah, we'll go for, yeah. One second. Yeah.
That's a first.
So there are a lot of questions among all of us, and even panelists. If any question comes to your mind, please ask. You're not there to answer, but you're there to ask also, because we want a good interactions more than just answering. And Dr. Manjunath has covered most of the points. Presentation was very good, but still we need discussion, because as he mentioned, we have to learn a lot of things Still, otherwise, the things will go out of control and it may become worldwide. So the first question I would like to ask, Dr. Jai is there uh, or he has not joined? Okay. Then I'll ask,
Sir, he is there. He is
is
there.
there?
Yes, yes, yes. He had
Yeah,
joined.
Dr. Amarkant, you're there? Dr. Amarkant?
He's there, but his video as well as audio is off. He might join, sir. I'll
Yeah,
let
yeah,
you know when
okay,
he
okay.
joins. Yes, sir.
Then I would like to ask Dr. Rajat because I heard his talk. Why, why this has become an ordeal to not only the patient but even dermatologists? Because treating dermatophytosis is really recurrence, relapse, partial response. So what is the reason, Rajat, according to you? Because I have listened to your talk, so I'm asking this question to you.
Sir, thank you for that, sir. I think there is not one reason. I think there are a host of reasons which have made refractory dermatophytosis become an ordeal to the dermatologist and also to the patient. So I think starting off with factors which regard to overcrowding and migration, that is one thing, and that has led to this becoming a thing which is much more found in certain belts in certain cities than we used to see earlier, much more in family members and so on and so forth. Secondly, as Dr. Shinoy sir mentioned in his talk, the use of topical corticosteroids
Yes, correct.
that has led to a local immunosuppression and led to the fungus becoming more active. And further, there are changes in the genetic makeup of the fungi which have been seen. There are mutations against certain drugs which have been seen, so on and so forth. And amongst this, also comorbidities with the patients and decreased compliance. All of this together, I think, has led to it becoming much more refractory than what we used to face earlier.
I entirely agree with you. All these factors are responsible, and there are still limited number of studies. We need more study because whatever the guidelines is given, literature is given. If you follow that, we are not getting any result.
Yes,
So
sir.
along with this, I think we need much more study. So we should, as a dermatologist, ask all pharmaceuticals that they must come forward and support our studies, and we should get involved in that study. So we'll go for the next question. Next question is, I'm asking Dhananjay.
Sure.
Dhananjay, because Dr. Shanoy has made it very clear. He has done the clinical trial for the topical, and I entirely agree. It's very difficult to conduct because the patients are not ready. The question is topical treatment enough in
So,
treating
so
TB?
in the current scenario, it's almost impossible to concur that topical treatment is enough, because when we were doing our post graduation, that was the time when there were a lot of treatment naive patients. But now we see that none of the patients has we come across as will volunteer that he has not taken any treatment. At times, maybe you're forced to give only topicals in certain scenarios, like Dr. Manjunath was saying that in pregnancy or in a child who has got a single patch, maybe just started, not treated. Those are the only situations where probably you can say that maybe topical treatment might work. I'm not saying it will work, but in the current scenario, it's impossible to say that the topical treatment is enough, and you actually need systemic for virtually more than 90 to 95% of the cases. And if I have to choose between the topicals, like we have been seeing the evolution of so many molecules, right from iconazole, ketoconazole, oxyconazole, sertaconazole. Sertaconazole was showing very good results, but then somehow after 1 or 2 years, the results were not so great. And when the laliconazole, which was brought into the Indian market, then it went off the radar, and then again it came back. It really has shown a promising result so far. So far, it has, I would say it has been a molecule which I have been continuing to use. For the last 3 years, I'm using majority of my patients laliconazole.
I entirely agree with you because most of the patients they come to us for the consultation Already they applied some ointment, and as Dr. Shanoy said, this abuse of steroids. They apply steroid, so definitely they are not remain as a virgin. What you are talking, and there are most of the cases are extensive or multiple patches where the topical steroid is topical antifungal is
Antifungal.
not enough. So we'll go for next question to Dr. Patnaik. What are the indications for topical treatment?
Sir, since more cases are now extensive lesions, so I think topical treatment will not be enough because chronicity of the lesions and the morbidity associated with it. So, and the lesions are extensive nowadays. Do not initially consult the dermatologist. They go to quacks and the chemist shop, use some ointment or cream, and then they get relief. So topical is not enough. We normally combine topical with systemic therapy, and in our place mainly itraconazole.
Yeah, any other panelists would like to add? What are the indication? Doctor, I think I'll ask Dr. Shana only because he has covered this topic. Dr. Manjunath, can you?
Sir, I would rather say, rather than indicated, I would say we have no choice situation. That is why we are using topical.
Yes,
Now, for
correct.
example, in pregnancy,
Yes,
because we can't use anything in a patient with liver disease, in
yes,
a chronic liver disease with deranged hepatic function,
yes,
wherein we know all systemic antifungals are metabolized to liver, and giving anything could be risky. That's the second. Bad renal disease. If you have a average, it's okay because itraconazole is relatively safe in renal patients. But you have a patient with end stage renal disease, or we have a patient with bad cardiac disease, wherein he's on multiple other drugs. He's taking drugs for other conditions, polypharmacy patients, where you are scared about all drugs could have interactions. Patients, especially patients on anticonvulsants, on cardiac drugs, you have to think about interaction. That is why you prefer to limit your usage of topical antifungal rather than yeah, it's an indication. It is basically we have no choice. That is why we are using. Otherwise, virtually like Dr. Damle mentioned and others mentioned, and in every case we need to use a systemic antifungal in the current scenario. Even in limited lesions, where, as mentioned by others, they are already immune suppressed hosts because of the usage of topical antifungal. Most of the times they are bought over the counter, and that is why it justifies using systemic antifungal in almost every case.
yeah.
Manju, I have a question.
Welcome, sir. Welcome. We have been missing you for long. Yes,
Thank you. I was hearing you from very beginning.
Yes.
You have given all the indications. In your practice, since you are an authority on this, what is the percentage of the cases that where you decide and you go only for topical therapy? Suppose you see 100 patients a day of fungal infection. How many of them you put on topical therapy alone?
Less than 5%, sir. And all these are pregnants, infant, hepatic disease. Otherwise, I would put systemic antifungal
in a normal patient,
normal,
if he is a newborn, he has never gone for any topical therapy.
Yes,
Do you think that if proper selection is done for topical therapy and it is applied once a day in laliconazole or twice in other cases, and if it is applied by rule of two, that it is applied to along the lesions in the normal effect part also, other than affected one, and we go on treating with topical alone for 2 more weeks after the apparent cure. What is your experience? I have seen in cases that it works.
Yes.
That they have never taken any topical therapy, and if we are giving either laliconazole or emerald, whatever is our choice, and if we give it for a very long period and then we stop, then it works, and there we don't get any recurrence after that. What is your experience?
If there are one or two lesions, I would use topical antifungal. And if they are localized to one region, suppose there is one lesion on the face, one lesion in the groin, I wouldn't dare using topical antifungal alone, if not contraindicated. Obviously, that word will come without this thing. So if it is one or two lesions, if there are more number of lesions, suppose more than 3% of the body surface, that means 3 palm size lesions or more, I would always prefer to use the systemic antifungal in addition to topical.
But is there any study that you give systemic for say 2 weeks, and then you stop systemic and continue topical
I
alone?
think Dr. Amar Khan, we are taking that question next.
Yes.
Anyway, it's a good
Okay.
question. But coming to your
Yes.
topical, I remember one of friend, he is a diabetologist, he is obese, he has got cardiac problem, he has got renal problem. When he had a tinea, extensive tinea on the abdomen, he said, you cannot give me any drug. So he applied this itraconazole lotion, applied for 2 weeks, and everything gone. He stopped it,
Yeah.
again he got it. So I said, you apply at least for 1 month. It has now gone, but we do not know about the
Many
recurrence.
relapses.
But the local, I think, to get a
Sir, local
yeah.
itraconazole lotion or loliconazole lotion?
Laliconazole.
Sorry,
Laliconazole lotion. Yes.
Sorry, laliconazole, absolutely right. Yeah, it was laliconazole. So, according to this, as you said, out of force, we have been asked to use the local, like the pregnant women, in the children, and as Dr. Shanal says, the comorbidity or the people are on multi-pharmacy and as an adjunct therapy. These are the indications for the topical antifungal. So I'll ask Dr. Santosh, what are the advantages of topical antifungal?
Yes, good evening, sir, and thank you so much for having me on this panel. Also, thank FDC for the same. Sir, if you permit me, I will also like to say something on our first question, that why it has become.
Definitely.
Yes, sir, I think the problem is multi-level, and it has started with the psychology of the patient, and it is a behavioral kind of problem. Why it has become, because most of the patients, when tinea starts, they don't think it is important to consult a dermatologist, and mostly the first point of contact person is a pharmacist. Then it is maybe a general practitioner. If fungal infection has occurred in a baby, they will consult a pediatrician. So there is no knowledge among general public that a simple fungal infection is an area which is to be handled by dermatologists. Rather, they would ask a physician, they would ask a pediatrician, or they would ask a pharmacist, and then they would prescribe this combination agents, and that is how the problem compounds. So if the something can be done to educate even pediatricians or say physicians and general practitioners, then this may help a bit more in our cause of treating tinea. Now, sir, coming to this, like what are the advantages of topical antifungals? So I think it has been very well described by Manjunath Shinoy, sir, that it is about like when we cannot use systemic ones, there we use topical antifungals. But then there are certain subset of patients, they think that even if we apply something on the skin, then only the disease will go away, or it is in their psychology that they like applying something, they like rubbing something on the skin. So maybe that placebo effect of topical antifungal is there, where they think that this topical is working and not the tablet that I'm taking. So that is one advantage apart from what already been discussed by Shinoy sir, that in certain situations like chronic liver disease, renal disease, infants and pregnant women, there they definitely have advantage. Yes.
I think, thank you, Santosh, for going for the root cause. And as you said, we have to train general practitioners whom they should refer. That is the big responsibility among us, all dermatologists. I think we have to take that responsibility. But as per
Yes.
the advantages concerned, already you have mentioned
So
that.
may I add something?
Yeah. Rajat.
I think one of the biggest advantages of using a topical would be that, it attains a good concentration at the site of action, at the site where we are applying it. That would be the reason I would be using it more than if I'm already putting the patient on an oral and I'm also giving, so we are sandwiching the fungus in a way. So at least it attains a good concentration at the site where I'm applying.
Yeah.
Sir, may I add one point, sir? In
Yes.
addition to what is mentioned, if this is not evidence based, in addition, I also feel that using a topical antifungal may reduce the fungal shedding, by which it might reduce the formation of fomites. So, patients have extensive disease, they are likely to deposit these fungal spores, the arthrospores on the beddings, on the sofa, And using a topical antifungal, at least in the initial phase of the therapy, may also help in shedding that, reducing the shedding. Yes.
Yeah,
It is
yeah,
not
I
evidence based.
agree,
Just
Manju. I agree that that's true.
yes, sir.
Yeah,
Thank you.
so the advantage of topical, as you say, that it can be used for the prevention. When the disease comes under control, we can continue as a prevention, correct, Dr.
Yeah.
Sharma?
Yes, sir. Recurrence to
That
reduce the
not
chances of
only
recurrence as well.
prevention,
Yeah.
also for maintenance therapy,
Yeah,
because recurrence is rather a rule in all
Yeah.
these cases.
yeah,
Absolutely.
So
maintenance
even
and the
for
prevention. Yeah.
maintenance, the topical therapy is of use.
Yeah, so for the maintenance and the prevention, we can use topical therapy. That is the biggest. Yeah, so when I was conducting, one of the dermatologists came out. He said, I'm using even extension lesions, I'm using only local. So he asked me, have you used local in extensive continuously? I counsel patient and happy with only local. So I would like to know the opinion of the all panelists, because they say, he said, why to use systemic? Because he said today time has come only targeting therapy. We have to target the tissue which is affected, then giving the systemic therapy or creating the side effects. So he was saying, I'm using only local application. Only thing, I spend more time with the patient. I explain to the patient, and he says, I'm happy. That was his experience. So I would like to know any panelists, what is their view on this?
Raple Saab, theoretically, he may be right. And in our case, as Manju said, in some cases we are compelled to use only topically. But in the present scenario, if you will ask the patient to wait for months and months, agony is such that you will be forced to use along with topical systemic also. In most of the dermatological practice, initially, when the lesion is extensive, we go for the combination. But once it is controlled and there are some few lesions left, then we switch over to topical alone. And if it is prolonged, as we discussed initially for maintenance, that is very good. But only topical in all the cases, I don't agree. And in my practice, I never do like that. As Manju said, in certain compulsions, in very limited lesions, we go for topical alone. Otherwise, I combine both.
Dhananjay, you would like to add
Yeah,
anything? Or?
though even though it sounds theoretically correct, but practically it is next to impossible to use topical on such an extensive area. I don't think any tubes or available preparations are in such huge quantities which are available. 50 gram is the maximum. If you are trying to use it anywhere for a whole body or a half a body, you are going to require 5 or 6 tubes in a day minimum, with once a daily application also. It doesn't become cost effective in the long run.
Yeah, I entirely agree with you. Practically, or most of us who are
Will be
practicing,
very expensive.
we
We may be happy, but patient won't be happy eventually.
yes, but yeah,
Other
but we
symptoms
have to go for the
are
research and we have to find out the way. Yeah, so the next question is Dr. Parja,
Yeah.
that if you are going to use systemic, because we come to conclusion we have to use topical and systemic together. There is no other way. We got to use it. So you would like to use from the same class or the different class?
Different class. Everybody is using from different class and that gives better result. I agree with Manjunath. He initially said about the itraconazole. We all are happy with this. And in my practice, though I've tried almost all the systemics available, even going for the higher antifungals, but ultimately it is itraconazole that gives the maximum, the best result.
Sir, have
And
you
I
used
give it
voriconazole?
to most of the people. Itraconazole.
Sir, voriconazole have you used?
I have used in many patients. Initially, I was getting very good results. In the cases where nothing was effective, and the patient took itraconazole many times, and even in some doctors, I have a documented study of voriconazole. But then again with voriconazole, once you stop voriconazole, and if you are not giving either itraconazole or any other drug, the relapses were similar as it was in itraconazole or terbinafine. Finally, I give in certain cases who are refractory to itraconazole, and then for some days, and then again I switch over to itraconazole, and I good good results. But in all these cases, if you are not giving topical therapy for a very long period, then relapse is rather a rule than an exception. So it is only combination therapy. Even if we go for voriconazole, we switch over to in 17 days to itraconazole, and we maintain with the topical therapy, and then we are satisfied and the patient is satisfied. I will invite Manjunath for his comments on this.
No, we'll ask Dr. Patnaik only what is your experience with voriconazole?
Sir, voriconazole, I have never used a very costly molecule. Yeah. We are using only itraconazole, and those who cannot afford, we are using griseofulvin. Griseofulvin micronized doses is now acting effectively. In our place, terbinafine is not at all working. Now is fluconazole working. So we are using itraconazole, those who can afford. And in medical college, itraconazole is not, supply is not available. So any poor people, we go for griseofulvin. And I have revised a new technique. I use one topical antifungal in evening, night, another in morning, and go for 3 to 4 months, and I get better results.
Yeah. So the
Saple Saab, Saple Saab, may I have one question from Patnaik?
Yeah.
Dr. Patnaik, you rightly said about griseofulvin, and of late many of us are again using griseofulvin. But do you have any experience of combining griseofulvin with itraconazole? Can it be given? Multi-drug therapy?
I have never, because both are hepatotoxic, so I have never combined.
With all parameters?
I have given rotational therapy, itraconazole for 2-3 months, again griseofulvin, assessing liver parameters. I have used that, but never I have combined.
Okay, so this is the
you have any experience of combining two antifungals systemic? Manjunath?
I think Dr. Amar Khan will come to the original question. Can we combine from the same formulation, same molecule, or the different? It is a very good, this discussion will continue, but the same. So as you said, some Patnaik using the different, but if you ask me, what we require the good concentration of drug, correct? Concentration of the drug should be good. So why not to use the same molecule? So the concentration of drug you are increasing, then using another molecules where the concentration of drugs you are not increasing. So I feel, and we have done the study and found the same molecule results are very good. So because if you are using other molecule, one way you're talking, the concentration for terbinafine is increasing. We need the higher doses. Itraconazole, we need a higher doses. These are the studies or these are the suggestions where you're using other molecules where you are not increase the concentration of the drug. So I think same molecule using should be enough, and that's why we have done the study. Now coming to the next question, next thing, as Dr. Amar Khan say, we have done one study with the itraconazole 100 milligram BID for minimum 6 to 8 weeks, 6 weeks. It can be 8 weeks to 3 months. And we have found if you increase your adherence and the compliance, the result with the itraconazole is very good. When it was good, the problem was coming itraconazole, the cost, or was the cost. Terbinafine is also cost. So we started using fluconazole daily 150 milligram, and the results are wonderful. We followed for about 1 year. So whether you use itraconazole, terbinafine, or fluconazole, all this. Dr. Patnaik, can you put on mute? Yeah. So all drugs are working. What is important is the adherence, compliance, and counseling. That is a very important part. So all these drugs are working, systemic drugs, and as Dr. Patnaik said, some of the people are using griseofulvin, but we need some study to support it. But fluconazole, now I'm doing one of the clinical trial with the ICMR permission. We found fluconazole working very well because the cost is a problem. And secondly, fluconazole is safer drug compared to itraconazole, because itraconazole a lot of drug-drug interaction, lot of side effects. Fluconazole even can be given in the patient is on renal dialysis or patient is a renal compromise. So compared to other, itraconazole cannot be given, and definitely fluconazole is a better drugs. That is our experience.
So,
So
Saple sir,
yeah,
this fluconazole 150 mg daily, you
yeah,
gave for how many days?
minimum 6 to 8 weeks, and the patient is immunosuppressed,
Yeah.
then 3 months.
Sir, what
Like
about,
they are rheumatoid arthritis with tinea, they or diabetes patient, they require the longer period. Yeah.
what about relapse with fluconazole? With
Yes, correct, correct. No, this is a good question. So
When you are, sir,
yeah, yeah. So we followed them for 1 year, those 100 cases. Out of 100, 82% for 1 year, there was no recurrence and no relapse. That is with itraconazole, fluconazole, even terbinafine. But terbinafine we have used 250 milligram BID, not 50 OD. So there's remaining 18%. 2% were on immunosuppressive drugs, rheumatoid arthritis, they were Visolon and methotrexate combination. I spoke to the rheumatologist. They said, sir, we cannot stop these drugs. So those patients even continue 3 months, 4 months. The minute you stop after 2 weeks, they used to get recurrence. So that is a big problem. Those patients on immunosuppressive drugs. But those patients of 16, they didn't have or repeated counseling, we could get good result in about 6 patients. Remaining 10 patients we could not. So the relapse was in only in 10% after end of the 1 year. But now as I'm doing this study of fluconazole, again, only fluconazole. Yesterday I was discussing with my team. We have completed about 50 patients. Out of 50, 3 patients after end of 2 months, that is 8 weeks, after taking fluconazole daily for 8 weeks, 3 patients, they got relapse 2 weeks after stopping the drug. So I was just discussing why I said our experience in our private patient, because the patients we are taking clinical trial, usually they are from lower socioeconomic group. So I said, what is the reason? And you will be surprised, which had the same experience in HIV, those 3 patients, they were not taking treatment for their family members. They used to take medicine from us, and they are giving some of the tablet to their other wife or child or brother. They are sharing those tablets. So adherence and the complex. So I was surprised. I said, how come 3 patients out of 50 are getting recurrence? Because in my private practice, I have not seen. So they said, sir, there are family members that are affected. The family members are, even it is a free in the clinical trial, they are not coming forward. And when they asked, they were sharing this tablet to their relatives. So this was the one of the finding yesterday. I got it because this is a very nice question about the relapse or recurrence.
Sir,
Anybody else wants to add in this?
I
Saple
just
sir,
want
Yeah.
to know
Saple sir, this
Yeah.
fluconazole we too are using, and in some
Pardon?
cases we are this fluconazole 150 mg daily. We
Yeah.
have given some patients in last 1 year,
Yeah.
and we too get very good results. But
Yeah.
in many of these cases,
Mm.
initially we combined itraconazole and fluconazole. But then in some cases we are giving fluconazole alone 150 daily, but we are not giving for such a long period. It is only 1 month. Regarding itraconazole, you said about updosing. There is one study
Yeah.
where it has seen that out of 100 plus brands of
Yeah.
itraconazole available in India, hardly 3 or 4 are actual itraconazole, where all the precautions have been taken to enrich it and to make it a perfect itraconazole. So brand matters. Not only itraconazole, any brand is as good as. What is the opinion of the panel about this, that we should go on an itraconazole brand which is well established and about which efficacy we are very much convinced? What is the opinion of the panel about this?
I think before that, Dr. Amakan,
Yeah.
Dr. Kabir Sardani is very well known for research. He's the person who is doing a lot of research.
Yeah,
So
yeah, yeah. I know it. I know.
his paper is there. If itraconazole fails, if terbinafine fails, fluconazole work.
Yeah,
And
yeah,
you
yeah.
see the concentration of fluconazole in the stratum corneum is 40 times more than the itraconazole and terbinafine. Terbinafine and itraconazole is 40 times more. Only problem with the fluconazole, the concentration remains up to 24 to 30 hours. So many doctors, they are giving fluconazole once in a week or twice in a week, where they are not able to maintain the concentration stratum corneum. So it has to be daily, not how you are using it daily, once in a week or twice in a week.
No, I'm using daily.
Yeah, if
Daily.
you are using daily, I think Dr. Shana also, he mentioned in the beginning of the talk that Dr. Shana, what are you also getting the same result like Dr. Amakan Jha or?
Yeah, yeah. Fluconazole at higher dose, it works like
Yeah.
itraconazole, I can say. But itraconazole is the one advantage is that it is a keratinophilic. It remains in the stratum corneum for much longer. For that matter, even terbinafine. Fluconazole would not remain in the stratum corneum for, as you mentioned, 24 to in 24 hours the concentration drops.
Yes.
That is why, as you said, it has to be given. When it is systemic fungal infection, it's a different ball of game. Here we are dealing with the superficial mycosis, where terbinafine itraconazole seem to be having advantage, but fluconazole is an alternate drug. It can be used. But today's topic of discussion, I think, topical antifungals.
Yes,
Yes,
correct, correct.
I
Anyway, but
think we
he
should focus
opens
a little
for.
Yeah,
more
yeah,
on
yeah.
that. Yes,
So
sir.
we'll go for that. So we'll go for the next
Exactly the
question.
reason I was asking the question actually, that
Yeah.
keratin adherence will not be there. So once we stop it, we should expect relapse at some
Yeah,
stage.
with it. Fluconazole.
Yeah, this is the good thing. See, when you're talking about the keratin adherence, the concentration in the keratin layer, because always you are worried about the concentration of the drugs. So as the day passes, the concentration becomes less. Even it remains there for two weeks, 3 weeks. Itraconazole is supposed to remain there for 4 weeks, terbinafine for 3 weeks, but their concentration goes down. So that ultimately we have to maintain by giving the more frequent drug than giving what is called is a pulse therapy. So now the next question is, of course, Rajat, I'll ask you only how long we should be use systemic drugs or even the local drugs.
Sir, I think there was a time when we were using for 2 weeks, then we went from 4 to 6 weeks now. And I think in extensive cases, longer durations do help.
Yeah.
Uh, Guidelines, there were times when 2 weeks used to do the job. Now I use at least for 4 weeks. If a normal itraconazole dose, I use for 4 weeks at least in all my patients.
Yeah. Any
So
other panelists they would like to?
in all my patients, in the first visit only, I make them kind of understand that they will have to take this for 6 to 8 weeks minimum. That makes up their mind to follow up on a regular basis. Of course, my target is 6 weeks. I don't give any patients below 6 weeks for extensive tinea. Of course, I'm talking about. If it's a very localized tinea, less than 10% body area, then 4 weeks is good enough. But gone are the days of 1 week or 2 week, even though the Western literature still mentions those timeline or durations. Here we don't get to see those results in that much time, for sure.
Yeah.
We at the first visit, I tell my patients that you should apply it at least 2 weeks more than the apparent cure. Once you feel there is
Yeah. Once you
reason,
get a clinical cure, you continue 2 weeks more. Yeah.
yeah, yeah,
That is.
that I follow in all my patients.
Yeah, but then I think Dhananjay, I agree with you because our observation is same. The tinea is extensive, then the period is longer. If the tinea is limited, the usually 1 month should be, the 4 weeks should be enough. But still, we should prepare patient for 6 to 8 weeks initially only. Yeah, so we'll go for the next question.
I had one question in my
Yeah,
mind.
yeah.
I also, like, from safety point of view, if we consider, I tried to search that when we use itraconazole for deep mycosis or and I found that maximum duration itraconazole could be used was 9 months. So I would like to have opinion of Shinoy sir, that as we get patients who have taken from very generic brand of itraconazole for more than 1 year also, now we are getting that kind of patients also. So what is the suggestion on long-term safety of itraconazole when used beyond 1 year?
Regarding itraconazole, in fact, we hardly have in literature on dermatophytosis.
That is what, yes.
That is the problem. But it has been used in systemic mycosis. It has been used in subcutaneous mycosis.
Yes.
It has been used in certain other conditions
So,
too.
sir, maximum
It is used for long.
duration I could find was 9 months. So,
Yeah. I agree with 6 to 9 months is the therapy duration which is mentioned for subcutaneous mycosis for
yes,
that matter.
yes,
So we probably are extrapolating. But only thing is, as long as we are doing the hepatic monitoring, I think there should not be an issue. Other than hepatic one issue and the drug interaction, which Saple sir rightly
yes,
mentioned.
yes,
Other than that, there is no major issues with the itraconazole. But one has to think about when you give it for a long time, it might interfere in the androgen production also.
yes,
That has
yes,
to because we don't know much about it.
yes, yes.
Yeah. I think Santosh, you asked very good questions. I'm talking the story of 98. 98, we are dealing with the cryptococcal meningitis. Cryptococcal meningitis, one of the company came and they said, sir, can you prescribe itraconazole for cryptococcal meningitis? I said, why you want to, why you want that? They said, sir, if you prescribe, we'll take you to Switzerland. I said, if you take a Switzerland, is very good. I'm ready for that. But itraconazole drug is not going to work in cryptococcal meningitis. It works only in the maintenance. So any systemic disease, itraconazole is not good drugs for the induction therapy. For the maintenance, we can use it. And as you said, we can use it for 8-9 months. But as Dr. Shanoy said, we have to monitor CBC, LFT, and serum creatine. That monitoring is very important in the long term. Yeah. So can you go for the next question now? Yeah. Choice of formulation, because the local application can be in the lotions, it can be creams, it can be gels, or it can be nail lacquers. So I'll ask, I think I asked Dr. Patnaik, when you would like to use lotion?
Lotion mainly in hairy areas, sir.
Yes.
The
Yeah.
scalp, hairy areas we use lotion.
Okay. And creams?
Creams in intertriginous areas.
Yeah, intertriginous lotions. Okay. Yeah. Okay. Any other panelist?
You have already mentioned, sir, about this. All these
Yeah.
lotions are meant for, and also lotions,
Yeah.
people use it for extensive area. When it's extensive,
Extensive.
it's easy
Correct.
to,
That's right. Yeah.
spreadability is better with.
Yeah.
Only thing is, lotions are, I believe they are slightly irritating as compared to the creams. There is some irritation aspect, especially when the
Yes.
badly excoriated areas are there, then we need to be a little careful. And even in children, it can produce, infants especially, we should be careful using lotion formulations.
Yeah. And nail lacquers can be used in onychomycosis. So
Okay.
we'll go. The very important point already Dr. Shana has discussed, but again, I would like to ask, how important is the viscosity? I'll ask Santosh.
I think, sir, it is very well described by
Oh,
Shinoy, sir.
yeah.
It is important with regard to the formulation and the release of active drug. Sir, also proper viscosity gives a good feel or maybe a relief to the patient in itching. So we should also look at how much it is those additive agent are helping with the itching as such. So if we can develop any such agent which provides viscosity and also have some antipruritic effect, that is, I think, should be the way forward in topical antifungals.
I think any other panelists would like to add
Sir,
to this?
in
Yeah,
viscosity will enhance the spreadability and it will also enhance the efficacy of the molecule.
yeah,
Yes,
absorption. Yes,
yes,
correct. That's right.
yes.
Yeah, Rajat, you would like to add?
If the molecule is getting delivered in a proper dosage,
Hmm.
I think with the formulation which has got adequate viscosity is only going to add to the benefit.
Yes.
Yes, correct. That's right. Yeah. So,
Sir, I just wanted
yeah,
to add one thing in
yeah,
topicals.
yeah.
Is that, sir, I use many a times topical antibiotics.
Hmm.
So whenever a topically steroid modified tinea comes to me, with a systemic antifungal, I use a topical antibiotic, simple antibiotic like fusidic acid or mupirocin, and that also clears the lesion of tinea very well. So this is the I thought I should share.
Okay. So,
Saple Saab, may I
yeah.
have one question?
Yes, yes, definitely.
You mentioned about the nail liquor.
Yes.
Amrolfin is
Yeah.
available as nail liquor since long. Of
Yeah.
late, there are certain creams also of amrolfin they advocate to apply daily on the nails, twice daily even.
Yes, yes.
So, Senwai, what is your opinion? If we have to treat a local nail lesion, onychomycosis, and if we have to treat with amorolfine, whether you will go for its liquor form or the cream one?
For the nail, very important is sustain. It should sustain. The product has to sustain on the nail. Definitely, the creams have a disadvantage. We have to use a nail lacquer, and amorolfine has mentioned in studies as well as the manufacturer once a week nail lacquer, especially for cases with the limited nail disease, maybe one or two nail disease, and where the nail involvement is less than 50% of the wherein we can use topical alone. Otherwise, systemic has to be used in.
You go for filing of the nails also before application?
It should be filed in order to remove the previous applications, rather than because nail disease is primarily a subungual disease. So hence it is more meaningful to apply on top as well as underneath the surface involved area. But filing is to remove the old nail lacquer and apply again.
Thank you.
Dr. Amarkar, Dr. Shenoy said, first thing, onychomycosis is very difficult to treat. Number two, the results are not satisfactory by using any drug. Number three, according to the literature, they have compared the terbinafine, but they say terbinafine is slightly better than placebo. Itraconazole with the long term, 1 year or 2 years, is because of side effects, it has got limitation. So only the best drug according to world literature is the fluconazole. Initially, you can give induction therapy for 1 week, 2 weeks, and can you continue for 1 year or 2 years, but still results are not satisfactory. So the nail association, they are suggesting you do the CO2 laser therapy and give the topical, then give it systemic. But I think still the study is going on. When we get it, we'll come to know. But one of the drugs for onychomycosis is fluconazole, according to world literature. But still results are not satisfactory at all. Any other Patnaik you would like to add in onychomycosis?
So onychomycosis, as Dr. Jha has opined, we go for nail filing to enhance the penetration of the
go for nail avulsion?
No, nail filing, sir. Filing before application of the nail lacquer.
Yes, correct.
Sir, as far as the onychomycosis is concerned, there are only 2 drugs approved, which is itraconazole pulse therapy or in daily formulation and terbinafine daily. When compared to these 2, terbinafine daily probably could have a slightly higher efficacy as compared to itraconazole. Fluconazole still not recommended for the onychomycosis, but that doesn't mean it doesn't work. Not recommended is not doesn't
Dr.
work.
Shenoy, today morning I showed the slides. Terbinafine is slightly better than I think I should have shown those slides, the world literature. Then itraconazole, because long term it is not advisable to use it, and fluconazole is supposed to be the best drug, but fluconazole with ketoconazole local give the best result. Local application, I think those slides I should have bought it here. Today morning I showed to all diabetologists. Yeah. That's why the literature says. Anyway, but results are not satisfactory at all. Yeah.
So I think in practice also terbinafine, this is one of the places where terbinafine does some job. And like Dr. Shenoy sir said, I completely agree with him. A daily terbinafine does a reasonable job and it acts on the non-dermatophytic molds as well. So this is one place where it does work, I feel.
No, Rajat. Terbinafine doesn't affect on the saprophytes and mold. In fact, fluconazole affect. Fluconazole is a drug for the systemic drug also. Fluconazole is useful for the saprophytes, for the molds, for tinea, for malassezia. Yeah, not terbinafine. But terbinafine we give, but I do not know what is the experience. Yeah.
So what I feel is, what you are talking about is onychomycosis, whether it is dermatophytic or non-dermatophytic.
It's a dermatophytic. We are talking about dermatophytic.
So I think itraconazole and terbinafine would be better molecules in this situation.
Yeah, because they I think as far as the dermatological studies are there, but if you see the world literature in diabetic onychomycosis, fluconazole is a drug of choice. Only thing, those paper I should have shown you here. I think today morning I showed to the diabetologist. Anyway, I'll say, I'll
I
Dr.
agree,
Chaple,
sir.
yeah.
Dr.
Maybe
Chaple,
because, yes,
uh,
yes, sir.
my
Jasar, please go
opinion
ahead.
is if it is onychomycosis, there
Yeah.
are many studies by Dr. Donkner and Dr. Gupta,
Yeah.
where, as Manjunath said, is pulse therapy, itraconazole, 2 tablets morning, 2 tablets evening, 100 mg for 7 days every month. If it is fingernails, 3 months. If it is toenails, 6 months. There are
4 months.
many documented evidences for this, and itraconazole has proved itself, along with the topical therapy, to be the best choice for onychomycosis.
Yeah, Dr. Amar Khan,
Yeah,
this Dr. Gupta, I asked him very simple question.
yeah.
Dr. Gupta, if the patient is on he is on immunosuppressive therapy and tinea, how do we treat? You know what he said? You give itraconazole for 2 weeks or turbinol for 2 weeks, and that's all. I said, then I said, have you treated any patient? He said, no, that is a clinical trial says. I have not treated. See, so these people are going by the clinical trials. We want the reality, ground reality. Now, you tell me how many onychomycosis you have seen good result. You have seen good result. Either with terbinafine, even I have treated with terbinafine for 6 months to 1 year with the itraconazole also. So, how many patients you have seen good result?
So there are two things here. One is a
Yeah.
mycological cure, other one is a clinical cure. The
No, but
problem with
we are
onychomycosis,
interested in clinical cure.
yeah, clinical cure, the problem is in
Yeah.
most onychomycosis cases, when they come at a very late stage, they would have irreparable damage to the matrix, in which case the nail will not grow morphologically normal. So that doesn't mean mycological cure is not achieved. Many a times mycological cure may be achieved, but clinical cure may not occur because the nail is deformed permanently. And other thing is, many a times these are traumatized nail which are infected. And when there are traumatized matrix damage is already there, then we are unlikely to have a morphologically normal nail. There the problem. Onychomycosis is a different game. So we need to understand onychomycosis, clinical cure, mycological cure, there is no correlation. So our idea while treating with antifungal is only mycological cure. Clinical cure is that is why we need to counsel the patients very well. The idea of treatment is, to get rid of the fungus. You may not get a normal nail, completely, totally normal nail. But having said that, I have obtained excellent results in many cases of both toenail as well as fingernail onychomycosis with the systemic antifungal therapy. But yes, not in all cases, as you said. Yes, sir.
Yeah, a few cases it must be good result because even some angual hyperkeratosis, they get it even after 1 year.
Yeah.
Yeah. Anyway, this is a very difficult subject, and I think we have to involve the people also. We'll go for the last question about the viscosity because now we are, as you said, the viscosity. What is important? The less viscous is, as Dr. Patnaik said, is a high spreadable and 100% absorption. What is required? That's why they count in the Pascal. Pascal, that is the 2.9 in valiconazole, and yeah. So when they're talking about that, as Dr. Shanal said, capric acid or caprylic acid, which is the medium chain triglyceride, which are easily spreadable, not only antifungal, it has got antimicrobial activity also, and it is always with the virgin coconut oil, which is well known for dry infected skin, xerosis, and moisturizer. So the less viscous is always acceptable. So they are compared with what is medium chain triglyceride. That medium chain triglyceride, that is capric or caprylic acid, is 100% absorbable. Drug release is very quick. Beside that, it maintains the skin pH, non-irritant, is a lubricant, antibacterial, antifungal, and is a coconut oil is a well accepted. So any drugs, any topical applications, when you have to apply, you have to see that whether it has a MCT, that is medium chain triglyceride. When you prescribe any company you prescribe, better you have to look for that if you are prescribing ludiconazole. And as last question, I'll start with Dr. Shanoy, that which local topical antifungal you prescribe maximum?
Currently, luliconazole, if a patient has no cost issues, so I'll keep those patients because of the cost reason. Often it happens that we compromise. I have more faith in luliconazole, and my study also said the same thing.
Yeah.
So definitely, I would like to prescribe luliconazole in more number of patient topical because I feel the relapse rate will be lower when I use luliconazole.
Yeah, but 8 years back when the luliconazole came, it did not pick up at all. 8 years back, I'm talking about.
At that time, Sattaconazole was preferred.
Yeah.
8 years back, there was only one brand, sir. That noise was less. Now there is more noise.
Yes.
So to have a noise is also required.
So there were no awareness program. I entirely agree. The awareness program was very less. So Dr. Patnaik, which topical antifungal you prescribe?
Luliconazole, sir. Luliconazole.
Okay, Dr. Amarkant.
Now luliconazole is also cost effective, 100, and there is a competition among the pharma houses to bring good luliconazole at the cheapest rate. And my first choice is luliconazole.
Okay, Dr. Dhananjay.
So same here, but followed by, in some cases, I also use ketoconazole.
Oh, ketoconazole. Do you get any irritant dermatitis?
I avoid in intertriginous areas.
Yeah, okay, but have you come across any contact dermatitis?
Yes,
ketoconazole?
You do get.
Okay.
Even with
my experience with other like luliconazole, miconazole, clotrimazole, if you get the contact dermatitis, use ketoconazole. I have used ketoconazole. There is no irritant dermatitis. That's what we have found because that is the thing which is working.
So even with luliconazole, you get patients who develop sensitivity.
Yes. Okay. Dr. Santosh.
Sir, I have very limited experience of using luliconazole.
So which you are using?
I have now till now I have used only in 3-4 patients luliconazole. So commonly I use miconazole, still giving good result of a very good company. And secondly, I use cycloperoxylamine and ketoconazole and ibuproconazole. So these are the topical.
Yeah, cycloperox is quite means is cost wise is okay.
Yes, cost wise is okay, and also it comes in different formulations like
there are hardly any resistant to cycloperox in the
and some patients who have extensive, I have also used the selenium sulfide, which comes for tinea versicolor. Okay. So the same way of application in tinea, like asking them to wash their body with selenium sulfide, has helped my patients of dermatophytosis as well.
Okay. Rajat, now you are remaining.
Sir, luliconazole and cyclopyroxolamine, usually. These are my
I think Dr. Shana is right. There is a big noise about the luliconazole and cyclopyrox because I was talking with Archana Singhal, I was talking with the other who are working in the general hospital, the government hospital. They say, even Rashmi Sarkar, they said clotrimazole is also working, miconazole is also working. Yes. So probably who are on the private practice, they are using luliconazole or cyclopyrox. Anyway, so most of these topical are useful. And so you can prescribe anything. I think we'll call it a day, Dr. Shanoy, because
Thank you very much, Dr. Saple.
Yes, sir, it
was an excellent evening. And thanks a lot, Dr. Manjunath Shanoy. You really started in a nice way. And my thanks to all my co-panelists. Thank you very much.
Thank you. It was a pleasure interacting with you all.
Thank you. Yeah, I think we can ask FDC people to take over. And
we'll open. Yeah, before closing, if there are one or two questions, we'll take up questions because you have covered up everything. So I'll just say. No, Ruchita, have you received any question?
I have shared with you, sir.
Okay. Yeah. How long fluconazole may be used in patient in dermatophytosis? We have covered 6 to 8 weeks minimum. What do you use locally with oral fluconazole? It's good because fluconazole. Usually most of us we are using luliconazole, but as we discussed, you can use anything. But better to use same thing. But Can we give daily fluconazole and for how long? That we have answered. Recurrent fungal infection, we have answered. How many we can give how many we can give? Okay, same. Apart from hepatic and pregnant patient, contraindication for itraconazole. Of course, drug-drug interaction, if the patient is on multi-pharmacy, itraconazole is a metabolism through liver, so it's better not to use where terbinafine is a drug of choice. But
Yeah, and sir, I just add one thing.
Yeah.
In cardiac patients, itraconazole should be very carefully used in congestive cardiac failure patient because it has a negative, and also especially most important interaction is the statins. While patients on statin, we should avoid itraconazole.
Yeah, atorvastatin, but with rosuvastatin,
Rosuva is relatively safe.
Yeah, you can use it. So Dr. Shanoy says the patient has got even a hypertension patient, you have to be very careful because you do not know that the heart is affected or not, because itraconazole can cause the congestive cardiac failure because of the conduction. The same thought was there about the fluconazole because the itraconazole and fluconazole are from the same class.
Triazoles.
So whether the fluconazole should be used or not, so I work on it and found there is one study. They are given 1200 milligram of fluconazole in 1000 cases of HIV, and they found the QTC interval with the fluconazole 1200 milligram and the placebo patient. The QTC interval was not altered, but the patient is already taking the drug like quinolone, like ciprofloxacin, levofloxacin, or azithromycin, or the cardiac drugs, then you should not use fluconazole. Yeah, because that will add the QTC interval. Yeah. So these were the question. Any other question from panelists, or we can call it a day and you can hand it over to Ruchita. Thank you everybody, Dr. Shanoy, Dr. Dhananjay, Dr. Santosh, Dr. Patnaik, Dr. Amar Khan, and Dr. Rajat for nice evening, and really we learn from each other. Today we learn a lot. Yeah.
Thank you, sir.
Yeah.
All right. Thank you very much.
Over to Ruchita. Yeah.
Thank you so much, sir. And our respected moderator, Dr. Professor D.G. Saple, sir, for arranging such an effective webinar on topicals. And thank you, Dr. Manjunath Shinoy, sir, for his talk on various topical agents available and superiority of luliconazole over other antifungals, topical antifungals. And of course, the last line conclusion, no steroid use, and can be used, topicals can be used in pregnancy, lactation, kids, and patients like hepatic and renal dysfunction. Thank you so much, all panelists, Dr. Amarkan Jha sir, Dr. Satyadarshi Patnaik sir, Dr. Santosh Rathod sir, Dr. Dhananjay Damle sir, and Dr. Rajat Kanhari sir for their insights on topical antifungals. And thank you so much, all the participants. Thanks a lot, sir. Take care. Good night, sir.
Thank you.
Okay.
Thank you.
Thank you. Thank you.
Thank you so much.
Yeah.